have a patient. Mr. Smith is 84, he has dementia, heart failure, diabetes. His wife cares for him at home. And his daughter visits occasionally, but hasn't been very involved in his care. He's become incontinent, he's spitting out his food, he's refusing to take his pills, and he's supposed to take about 20 pills per day. He's had several falls, and Mrs. Smith is afraid that she won't be able to get him up. He's lost about 10 pounds. Mr. Smith's last hemoglobin A1C was 6.8, blood pressure is 104, and LDL was 56 3 months ago. What do you recommend? We're videotaping this, so we need to see if people have answers. We can get it on the microphone. I don't know if that'll be possible, but what do you do for this guy?
Get rid of the meds.
Get rid of the meds. Okay, good. Okay, are you stop them all right off the bat?
No.
Yeah. I've taken that approach. Let's just stop them all and see where you settle out. What else? What are other suggestions? Yeah, way back. Maybe you say it and then I'll repeat it.
Well, I'd be interested to see like where he's falling and if there's ways to make that environment safer.
Yeah, good.
Just like little steps and then another little step. Yeah.
So you're saying, ways to make the home environment safer, prevent the falls. Where is he falling? Take little steps. And that's actually one of the most important points, isn't it? That if somebody like this walks into my office, what do you think I do? Groan, yes, panic, Sally, thank you. I mean, right, this could take me the rest of the day and probably all of tomorrow too. But, because this is terrible, yeah, at the back.
I was just saying, rule out UTI.
Rule out UTI, good, yes. So think about potential medical things that could be making him start to have, worsening geriatric syndrome type things, right? But really, this is kind of the bane of our existence, isn't it? People come in like this and we think, oh my goodness, where do we start, right? So, some questions I might ask, and I think this is what you guys came up with as well, is it still a priority for him to take all of these pills? I think we'd probably all agree the answer is no, but if he's taking 20 of them, how are we going to figure out which ones to stop now, which ones to leave for a while? What can Mrs. Smith expect in the future? For all of you who aren't doctors, how many of you think we're very good at telling our patients that? How many have had a patient or a client whose doctor actually told them what to expect?
A family member.
A family member. Did the doctor tell them what to expect?
Actually, she told us just the opposite. So we brought him home waiting for him to get back to independence so we could put him back in his independent living. We paid rent for 6 months.
So somebody who had cognitive impairment, the family was told that it might improve and you should keep paying rent on the independent living spot. I am so sorry to hear that. Okay, yeah, unfortunately, doctors are not always very good about thinking about prognosis and what are the next steps and what's coming down the line. And one of the things that we're going to talk about it a little bit here today, and I would encourage that all of us in the room, whether we're a doctor or not, probably needs to understand and be involved in that conversation, because it really does take a team to be able to think through what's going to happen down the line with this patient. And then, of course, how do we optimize quality of life? That's our biggest concern, isn't it? We want both Mr. Smith and Mrs. Smith to have the best possible life. There are a lot of tough things going on with this family, and it's really our top goal to ensure that that things are going as best as possible. And then, of course, that most important question, is he in the right environment? Is it still safe for him to be home, or do we need to think around some other things? All right, so this is newly put up by the American Geriatric Society. How many people have heard about this multi-morbidity framework that's been developed by AGS? A couple people. Came out within the last year. Cynthia Boyd is a colleague of mine who did a lot of this work, and really some wonderful things in framing how to think about multiple chronic illnesses. And there's really 4 key features to it. And I love the fact that the absolute first one is elicit patient preferences. So how many times do we start and say, well, here's your disease, here are the pills, blah, 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 right? For lots of different illnesses. And really, if it comes right down to it, what we should be saying is, what do you care about in life? What are your goals? What do you want to accomplish? I saw a 94-year-old in clinic this week, and I said, what are you hoping for? And she said, well, my family gets together at Black Butte every summer, and people come from the East Coast, and I want to make it there. And I said, well, okay, that's not too far from now. So end of July, okay, I can do it. So thinking about the patient preferences and really eliciting those preferences. Do people still want a longevity approach? There are a few people. I've got a 95-year-old who still beats her grandchildren at Wii. Like Wii tennis and stuff. She's in a wheelchair. She said, yeah, I want to make it to 100. She's got a longevity approach, and she's on Coumadin for atrial fibrillation, despite the fact that she's 95 years old, because she wants to make it to 100. She's doing really well. And not only do we want to elicit goals, but we want to make sure that we go back to those goals. Because as disease status changes, as age changes, people might change their goals. And where they might have had more of a longevity approach, they might say, you know what, my quality of life is not as good now, and I want to go back to more of a quality approach and not worry about longevity so much. This second one is a little bit of a tough one, because those of us who think about research and think about medical studies know that most of the research trials were not even done in the patients we see. If you look at studies, our patient here has congestive heart failure and diabetes, right? How many studies do you think were done in 84-year-old patients with dementia, congestive heart failure and diabetes? Probably zero, right? They do trials in young people who have a single disease. So in some ways, we might start to say, well, forget the evidence. It just doesn't exist for my patient. I'm just going to, kind of figure out what works for them, and I'm not sure that's the best approach either. But really what this says is that we should think about the evidence, think about what might be out there, apply it when it's relevant, and also make sure that we're not following it too closely and saying these chronic illnesses have to have too tight of management. And then consider treatment complexity and feasibility. I had an 82-year-old guy who was hospitalized with a heart attack. This guy had been pretty healthy in the past. His only medications were thyroid medication and Viagra. At age 82, I said, more power to you. The cardiologist put him on 7 new pills, some of which had to be dosed 3 times a day. So, guess what happened? He leaves the hospital. He didn't say a word to the cardiologist. He leaves the hospital and goes home, and 5 minutes later he's on the phone to my office saying, what are they doing? They can't give me that many pills. But he said, but I need my Viagra prescription. And I said, did anybody tell you you're not supposed to have sex for 4 to 6 weeks after a heart attack? Oh, no, nobody had mentioned that to him. Anyway, so I called the cardiologist and I said, okay, you get to choose 3 pills and they have to have once daily dosing. And I did not let that cardiologist hang up until we had figured out which 3 additional pills were going to get added. And I mean, 3's a lot. If all you're taking right now is your thyroid and some Viagra, right? 3 new pills is a lot. So thinking about the feasibility and the context and what that patient wants is very important. And then, of course, risks, burdens, benefits, and prognosis. And that gets into the side effects, but it also really gets into what are we trying to do here? How long does this patient still have to live? And when we're talking about chronic illnesses, a lot of times the pills are for longevity, and our patients no longer have a longevity approach. So that's kind of a bottom line there. How many have seen this curve? And I realized I accidentally put up the women instead of the men, but Mr. Smith is a man, but it's men are lower all along the way, but I like this. This is a table of life expectancy, and this is Louise Walter's work down at the University of California, San Francisco. And basically what she did is she sorted out into people who were in the top 25th percentile of health, people in the middle 50th percentile, so a bigger group, but right in the middle, and then the lowest 25th percentile. And you can see that if your health is poor rather than good, your life expectancy is much less, isn't it? Just thinking about Mr. Smith and what he's got, which line does he fall on, do you think? He's the lowest 25th percentile, isn't he? So why in the world does he have a hemoglobin A1C of 6.8, right? Because when you don't have that many years to live, and men are lower than women, so he's got well less than 5, why would you be doing such tight management of his hemoglobin A1C? Now, one question we're going to have to figure out is how to do this, all this pay-for-performance stuff. And when, this is not just the doctors and the nurse practitioners. As ambulatory practice moves into more team-based care, nurses, the pharmacists, everybody's going to be held accountable for some of these pay-for-performance measures. And I think the VA is actually doing it quite nicely. David might know a little bit about this, but they've relaxed targets quite a lot for some of the VA patients who have much lower life expectancy. And I think we all need to implement some more of that. All right, now, who here wants to put forward a guess as to what Mr. Smith's life expectancy is right now? He's 84, he's got moderate stage dementia, right? 3 years? 2 years? Yeah, it's pretty low, isn't it? We do some guessing around prognosis, don't we? We have a lot of, I've been around a long time. Some of you have known me for 25 years. A lot of us have a lot of experience, and we think we might be getting fairly good at guessing life expectancy. And turns out, some of us aren't right. Now, in the end stages of life, we tend to be pretty poor. So for people who died within the next 6 months, 50% of doctors said they weren't going to die that quickly. So we're pretty poor. But when we kind of put a gestalt of a couple of years, we're not that bad. But there actually are some tools to help us these days in establishing prognosis and some different scales that are available. How many of you have seen this ePrognosis website? Anybody seen that yet? So this has been out, oh gosh, probably about a year now, also by colleagues from UCSF, and it's eprognosis.org. And basically, it's a little hard to see on this, but each of these bubbles is a different prognostic index. So each bubble tells you about somebody's particular scale for thinking about prognosis. This is my colleague Sei Lee, who did a 4-year prognostic index. He actually just published data recently in JAMA on the kind of 10-year expansion of this study, so I think they'll be redesigning the site to get that on. Mara Schoenberg has one for both a 5 and 9-year prognosis. And when you look at this, the size of the bubble is related to the strength of the research behind it. So the bigger the bubble, the stronger the research study that developed that bubble. And some of them are for ambulatory and some of them are for long-term care. So you can also click on whether you want to do a scale for somebody who's in a long-term care facility versus somebody who's living independently in the community. But then once you've clicked on one of your bubbles, and I'll often do a couple of them to see how they compare, it allows you to plug in various things such as age and gender, and are they a smoker, and do they have congestive heart failure, and can they walk 2 blocks, and a lot of different things that can help us get a sense of what their life expectancy is. And I would argue that when we make decisions about managing multiple chronic illnesses, we should do it in the context of having a sense of prognosis. So we should be thinking about this in terms of what possible life expectancy might be. Now, of course, some people are going to beat that, aren't they? One of the fun things that this is probably not what I'm supposed to be doing, but when I talk to my colleagues who have developed the skills, they're like, wow, I never thought of that. But sometimes it's like if somebody doesn't exercise and can't walk 2 blocks, I'll show them what their prognosis is, and then I'll plug it back in as if after they've been exercising, now they can walk 2 blocks, and all of a sudden they get like 4 extra years of life, and it can be a really good motivator to get people to start exercising and to get them to do some of the things, get them to stop smoking. Boy, do you ever get a lot of years if you stop smoking. And so that can kind of provide some incentive. And I've had people say, I don't want to die in 3 years. And if I stop smoking, I might live more like 6 or 8. I'm going to stop smoking. So giving them some numbers can be helpful for some people. For some people, it's a little grim, so you have to be a little careful there too. But anyway, this is a great tool. And if you like to double task, you can go on your iPad or whatever you've got with you today and start playing around on it while I'm talking here. But it's a really useful site. Now the next question you might ask me is, okay, I'm trying to think about this. I'm trying to think about life expectancy. I'm trying to think about prognosis for my patient. But I'm a little squeamish talking about it because I don't know whether my patient wants to know about that. There are some people who say, doctor, just take care of me. I don't want to know how long I've got, right? And I think a lot of us are uncomfortable putting things that way. Well, you've probably got another 3 to 5 years, or you've probably got another 2 to 3 years. But it turns out when you do the research on these types of questions, people do want to know. And for the patients, a little bit over half of people want to know. But if you ask the caregivers, and I'll bet most of you already know this, if you ask the caregivers, even a higher percentage of caregivers want to know what the prognosis is, what they can expect for their loved one. So these are very important questions that can be really helpful in thinking through the patient and family. All right, so how can you talk to Mrs. Smith about prognosis? Do you want to try something?
Well, I would just say, ask her what she thinks first.
Ask her what she thinks first. Boy, is that a good way to do it. I think I do that about 99% of the time. So, what are your thoughts? What are your thoughts? What have you seen happen with Mr. Smith? And what do you think is probably coming up next? Those kinds of things. Absolutely, that's a great way to start. What else do you want to do? Yeah.
I think it's nice if you can have a member of the family with.
Yeah, absolutely. Have a member of the family with them. So if you are thinking along the lines about life expectancy, what might be coming up, it's really good to do that with a family member present so that everybody can kind of hear it together. And sometimes I'll actually set up a family conference to have that conversation. And for people that work in long-term care, when you guys have planning conferences, a lot of times those don't include discussions of life expectancy or prognosis, but it's a good time to think about it and to start bringing it up so that everybody's kind of on the same page about what might be going on. Yeah. Yeah, so ask her what she thinks. That's my first thought too. And then another thing is, if, a lot of us might meet Mr. Smith after he's already got dementia, after he's already having problems. So it's hard to ask him what his goals are anymore. He's not able to articulate what his goals are anymore. And it's really important to have that family member there, because you can say, what would he have wanted? Did he ever tell you? Did he say, well, I would never want to have to live in a nursing home, right? That happens pretty regularly where poor Mrs. Smith is taking care of him. And he says, don't you ever let me get put in a nursing home.
And worse yet, she has promised him that
she has promised him that she will never put him in a nursing home, right? That's one of the toughest challenges we deal with, isn't it? So, but eliciting his goals. We've got to figure out how to meet his goals, but do it in an environment that's going to be suitable for both him and for you, right? Yeah.
In this scenario, are we expecting that the daughter actually has a full comprehension as to the situation,
the daughter or the wife or anyone else has a full understanding of the situation? Yeah, so that's a good question. So Mrs. Smith or that daughter who actually isn't visiting very much right now, probably because she's so sad about what's happening to her dad. Yeah, exactly. That's her own family. And do they understand? I mean, I think a lot of people, Judith up front said, well, we paid for 6 months for his independent living because somebody told us he was going to get better. And, Mrs. Smith may still be thinking that he's going to get better, that this can go away. And I have lots of families who are like that. So setting more realistic expectations about the chronicity and the progression of this disease is incredibly important. And I'll bet Dr. Harbath and probably Dr. Mansour might be talking a little bit more about that after the break.
Mrs. Smith could also have early dementia.
And Mrs. Smith could also have early dementia. And that's a really tough one because sometimes Mrs. Smith isn't your patient. So it's not like you've seen her and been able to do a cognitive assessment on her as well. But it could be that she is having some concerns of her own, and really the situation could be way worse than even just what I've put up here on the slides. That's a great point. So thinking of that caregiver and what their own assessment needs to be is good. And I can't tell you how many times I say to the caregiver, could you talk to your doctor about your own memory? And she's watching her husband decline, and the last thing she wants to hear is that she might have memory concerns too, right? That's a really scary thing, but unfortunately we do have to go there sometimes. So here's another slide about expectations. Not only might people have a misunderstanding about whether Mr. Smith is going to get better, but they also might have a very poor understanding of what's to come. We've seen this. We know that people with dementia should not be resuscitated, right? There's very, very, very little chance of anything good happening in resuscitation. They're going to end up not being able to eat and swallow. And you know what? It is so much better for Mrs. Smith to have heard that before it happens. If you wait until Mr. Smith can't swallow, and then you start talking that this is part of dementia, Mrs. Smith is not going to be able to take it in, and she might say, why don't you give him a feeding tube? If you've talked about it in advance, and you've been able to lay the groundwork for the fact that feeding tubes don't do any good, they don't increase life expectancy, and they don't improve quality of life in people with dementia, she'll be on board and understand that supported feeding and helping with continuing as best as possible with oral feeding is the best way to go. And then really kind of thinking about the other medical problems in the context of the dementia. So a lot of us kind of have the problem list, right? And we have a problem list for our patients. And on that problem list is the diabetes and the congestive heart failure and the dementia. And I would argue that we should probably have the dementia up at the top of that problem list. Woo-hoo! Because everything else needs to be framed in the context of the dementia. People with dementia can't remember to take their pills, although they might tell you they're taking them perfectly. I've started getting little notices from the pharmacy. Your patient may be non-compliant with medications because they have not filled their prescription on time. Wow, that is so helpful. I mean, it just started happening in the last couple of months, and I love it. But it's really hard to think about the dementia or the other medical illnesses if people have dementia and have all of these problems start to arise. And then, once you've kind of couched it all in terms of the dementia, how do you think about the other chronic illnesses? And I would say that we've still got some priorities, and we probably can't just stop all 20 pills at once and hope Mr. Smith does okay. We want to think about symptoms. He's got congestive heart failure. Maybe he's had a lot of trouble with edema. He needs a diuretic to keep his heart failure controlled well enough that he's not suffering from things like that. Maybe he's had a lot of shortness of breath. If there are symptoms related to a chronic illness, we may need to try to figure out how to get those pills down so that that chronic illness can have a reduction in symptoms whenever possible. Relax the targets. You know, for things like diabetes, hemoglobin A1C less than 9 is probably reasonable for a guy like this who probably has 2 years, maybe 3 years life expectancy at the most. He may not need any diabetic medications. He's already spitting out his pills. He's probably not eating as well. That might be something that we can totally take off. And consider all medications targets for reduction. You know, there are so many doctors, I can say that because I am one, who just say, well, he's been on this for 30 years. He probably needs it. And you know what, if he's on a thyroid medication, that could be true. I don't often do dose reductions for thyroid medications, but if they're on, you know, digoxin, if they're on medications for kind of other chronic illnesses for which they're not complaining about much anymore, it is worth doing dose reduction and elimination for drugs in every possible situation. I had a lady who's now, she's unfortunately only 72, and we just put her in a dementia memory unit last week. And she'd been on a couple of drugs to manage atrial fibrillation. And we decided, you know, she's actually reaching pretty end stages. She's only speaking a word or two. She needs help with all of her ADLs. And we thought, you know what? We're going to taper all of these drugs. She's got a pulse of about 100, 110 off her drugs, but she's totally comfortable. She smiles. It's not bothering her. So all drugs can be targets for taper if things are going well. All right, how many know about the Choosing Wisely campaign? A couple people again. So Choosing Wisely is from the American Board of Internal Medicine. It's a national public awareness campaign for people from all medical specialties. And there are some Choosing Wisely suggestions for people, for nephrologists and cardiologists, and really all of the specialties. And the Choosing Wisely geriatrics ones are mostly around dementia. So I thought I'd show you this as well, because there are some public health campaigns going on, and I think these are very important and very well thought out choosing wisely things. And they're around don't do things. So, you know, as we already talked a little bit about, don't recommend feeding tubes in dementia. Don't use antipsychotics. That's a tough one, isn't it? Sometimes there's nothing else, but we want to have lots of other trials first, and luckily Dr. Mansour is going to tell us how to avoid antipsychotics. Don't try to get that hemoglobin A1C less than 7.5. At the bare minimum, if their life expectancy is low, you're going to have an even more relaxed target. Don't use the benzos and other sedative hypnotics if you can get away without. And then, this is a little interesting one. We have so many of our dementia patients for whom they seem to get like more agitated or worse, and we check a UA and it's positive. And what do? We treat them for a UTI, right? It may not be the right thing to do. If there's no change in their urination pattern, if they're not more incontinent, if they're not going more frequently, if there's no urinary symptom, it may not be appropriate to treat a change in cognition and a positive UA, because they may be completely unrelated. So, Mrs. Smith and her daughter together decide on some goals of care to allow natural death, no feeding tube, and medication minimization for Mr. Smith. They find a good memory care unit, thank goodness, huh? The facility team helps to plan a smooth transition with bringing in some familiar, furniture, things like that, some favorite food and music for when he first arrives, keeping the meal times and the bedtimes consistent. Mrs. Smith and the daughter can spend more time together. Daughter starts to come to visit mom and dad more often. Mrs. Smith joins an Alzheimer's disease support group, meets several women who help her adjust to having her husband in the facility, because, I mean, she's been with this guy 24/7 for like 60 years now, hasn't she? So that's a huge adjustment on her part, and also can give her some tips on how to improve her own health. And we're going to skip the falls part because I think people are ready for a break. This will be up on our website, and if you want some of these fall slides, I'm, certainly happy to give them to you. So, anybody have questions?
What's the website that you keep referring to?
Well, we'll have it on the Oregon Geriatric Education Center website.